This podcast is for informational and educational purposes only. It is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Patients in need of medical advice should consult with their personal healthcare provider. From UPMC Children's Hospital of Pittsburgh, welcome to That's Pediatrics. I'm Brian Martin, Vice President of Medical Affairs here at Children's Hospital.
And I'm Amanda Pahalik, Assistant Professor at the Department of Pediatrics, also at Children's Hospital.
Our guest today is Dr. Patrick Kochanek. Dr. Kochanek is an internationally respected researcher on traumatic brain injury and cardiopulmonary arrest. And he's also the leader here at Children's and UPMC for the Safar Center for Resuscitation Research. He's been the director for 25 years and established the Safar Center as one of the leading sites in the world for investigation of traumatic brain injury and cardiopulmonary arrest. Focusing on bench-to-bedside investigations for traumatic brain injury and cardiac arrest related to mechanisms involved in the evolution of secondary brain injury, translational neuroscience, and the development of novel therapies and interventions that can be implemented at any point in the chain of survival, from the field all the way through to rehabilitation. Welcome, Dr. Kochanek.
Thanks for having me. It's a pleasure to be here.
So how we generally like to start these off is just can you tell us a little bit about, you've been with us here at Children's Hospital for some period of time. Can you tell us a little bit about what brought you to Children's, a little bit about your history, and in particular, maybe what sort of drew you toward, research on traumatic brain injury and ultimate rehabilitation for the aforementioned conditions?
Well, I came here in 1986, and one of the big attractions to me to come to Pittsburgh was the fact that the legendary pioneer, the developer of CPR, Peter Safar, was a professor here at the University of Pittsburgh. If you don't know, Peter Safar in 1956 developed CPR, and ultimately, he set up a center called the International Resuscitation Research Center, and that was in 1980. And he had also developed the first intensive care training program in the United States in Presbyterian Hospital. And so that was, being someone who had just completed their fellowship in critical care at National Children's in Washington, D.C. in 1986, that was a pretty big attraction. And I came here and joined the pediatric critical care faculty then. I was recruited here also by Ann Thompson, who was the director of Children's ICU then and now is one of the deans of the medical school. And I slowly but surely had some successes in developing a program. I'd say I was really interested in, if you want to call it, the brain as the final frontier of critical illness. Obviously, we can save a lot of patients, but we all want to save patients and have them totally intact. And so targeting brain as the key to optimizing outcome has always been really my number one goal. And I then ultimately was given the offer to be the director of the International Resuscitation Research Center in 1994 and took it. And of course, my first act was to rename it the Safar Center for Resuscitation Research, which was a very smart move. And since then, we were initially on the main campus up until 2017. And even though my roots, of course, for many of those years, the old Children's was also on the main Pitt campus. And certainly with my own roots in critical care for children, many of the programs in that center have evolved more toward pediatric brain injury. Although about half of our faculty, even here now at the UPMC Rangos, are adult and about half are pediatric. We moved here in 2017. The university was amazing in building us an incredible facility here. And they've been amazing to us. And We have faculty, I have about 16 investigators in critical care, in neurosurgery, physical medicine and rehab, emergency medicine, pediatrics, and other disciplines. And we're all kind of working together to try to develop new therapies, new monitoring, new approaches to optimize brain injury in critical illness. And we focus on two diseases. We're not totally restricted to two diseases, but we've focused on severe head injury and cardiac arrest. And that is largely because in pediatrics, the two most common causes of acute brain injury that lands you in an intensive care unit are traumatic brain injury or cardiac arrest. And cardiac arrest in children, although not exclusively, is predominantly from asphyxia, drowning, choking, trauma, those type of things. And so that's really kind of the story of how I'm here. And we've been very fortunate at the Safar Center to have a lot of successful investigators working on some really cool projects that are really bench to bedside. We have people doing preclinical work, and we have many people doing big data research or involved in large multi-center trials and some really exciting nationally recognized, internationally recognized programs. I think we're very well respected and kind of I think a really nice component of the critical care piece at Children's.
Oh, that's super interesting. I really what struck me really there at the end was your comments on the bench to bedside. So I feel like that's something that as a non-clinician I hear a lot, and I'm super interested to hear about an example where, especially something that you can maybe tell us that's even maybe been in the somewhat recent years about a situation where a bench to bedside situation was really targeted to even like a set of patients or even a particular patient. Because I think that that's always something that really draws people in or draws me in to hear about those types of examples.
Well, one of the things that we're very, very, you may or may not know, if you want to think about it, the only truly successful new therapy that's not just supportive care for acute brain injury has, of course, been hypothermia. And mild cooling and or targeted temperature management, the prevention of fever. And our center really was instrumental to the development of that. Most people in pediatrics think of the neonatal trials, but prior to the neonatal trials, our center developed, and one of our graduates led the European multi-center hypothermia trial in 2002 that broke the field open. It predated all the neonatal trials. It was a big New England Journal of Medicine publication. Peter Safar and I wrote the editorial on that paper in the New England Journal. And it was really preclinical work in the Safar Center that led to the idea that mild cooling can improve outcome. And those were landmark kind of early studies. And then in the neonatal world, they followed with, again, preclinical studies. I believe their studies used sheep, if I remember, and led to the translation to the human. And more recently, some of the, if you want to think of the bench to bedside things that we've been working on, for decades, we've treated brain swelling in a very kind of crude way, things like mannitol, dry out the brain, if you want to think it, or even having to resort to a decompressive craniectomy and remove part of the skull to allow the brain to swell. And those are pretty crude, but they're part of the current standard of care guidelines. And so we've been working really hard for the last 5 or 6 years trying to develop new drugs and develop and test new drugs that can prevent brain swelling before it happens. And I have been very fortunate to have a number of young investigators working on this, but also to be the lead investigator for the United States Department of Defense in a program called Operation Brain Trauma Therapy. And it's a multi-center preclinical drug screening consortium funded by the United States Army. It involved our center, the University of Miami and the Miami Project to Cure Paralysis. It involved the Virginia Commonwealth University and Walter Reed Army Institute of Research. And we all have been working together and then screening across multiple models. Does something show promise that can work in multiple different models? Because, you know, there's so many different forms of head injury. Somebody's hit by a car and has a contusion. Someone else falls and has a diffuse injury. There's just someone has an epidural hematoma. I mean, the phenotypes of it are so diffuse, but most drugs that have been tested have failed, and they're largely tested by one lab in one model. And so we pioneered and spearheaded this idea and received a lot of funding for a multi-center consortium. And we're really excited to say that one of the two drugs that showed the most promise in our multi-center consortium has now gone to a large multi-center human clinical trial in adult traumatic brain injury, and that's this drug glyburide, which has been used to treat diabetes, but seems to have a more potent effect on an ion channel in the brain at doses that don't even lower your blood glucose. And we did not discover that, but we validated the findings of another single lab across all of these models. And so it's really an exciting finding of kind of a new strategy for translation where you do multi-center preclinical trials to mirror the multi-center human trials. And that drug now is in a large multi-center clinical trial. The other thing that's really exciting about this is that the work of one of our investigators, Ruchira Jha, who literally was just recruited and moved to the Barrows Institute in Phoenix, has identified a number of gene polymorphisms that we think are going to help predict who's going to swell badly after a brain injury and who's going to just not swell, because we'll get two patients in that look pretty similar on the first day, and one the next day, the pressure in their brain is off the charts, and the other one hasn't swollen much. And we used to always attribute that to the severity of the injury, but it didn't always make sense because some of them had really similar sounding severities, and the genetics of this channel they really look very important to determining how badly someone's going to swell. So I think this bench to bedside thing, I think it has really proven to have a great opportunity here. Hopefully the clinical trial will be positive, but it's a large multi-center trial and kind of very exciting, really exciting.
That's fantastic, Dr. Kochanek, to hear a couple of those examples. Two things sort of were brought to mind. The first, could you touch on the evolution of support over the years for resuscitation research, and one of the things that you spoke about in regards to particularly like Department of Defense support for this type of thing, and have you seen an evolution really in the last 20 or so years? I'm aware of some of my friends that are in plastic surgery that have had a lot of support for traumatic reconstruction and grafting and things like that on their side in terms of research support. And so I'm wondering if you could just give a little history of that and maybe how that might come along. And then secondly, Are there examples where you'd say that where your research actually transcends even within the walls of the hospital, i.e., either examples that you might have had where you've given data and perspective over to primary prevention and some of the safety work that hospitals do, and or specifically maybe like the pre-hospital environment? I have a very distant history as a pre-hospital EMS provider, going 30 years ago now, and some of the things you're talking to me are interesting because that state of the art, if they're the first person to lay their hands on the patient, so to speak, that's sort of where the time, the continuum starts, if you will. So love to hear your thoughts on those two pieces.
Great, they're really cool questions, and I think we have some very unique perspectives on both of them. The support one, you'll really be excited to know that in 1955, Peter Safar submitted a grant that was a half-page letter to the United States Army, and he received $50,000, and $50,000 funded the development of CPR.
That's a great word to dollar ratio in 1950.
That's incredible.
And what's really amazing about that is that from that point forward, the Safar Center, in essence, its legacy, have always had a strong relationship with the Department of Defense. And they obviously are interested in trauma and resuscitation, and you could look through our portfolio. They're a logical connection, but the one thing that the Department of Defense is always interested in is in translation, products. They want a difference. And that's not to say we have a large NIH portfolio of grants, and generally a little more NIH funding than DoD funding, but funding from the Department of Defense, Combat Casualty Care, and the Veterans Administration have remarkably always been a staple of this center. And again, I think it gets down to the practical, trying to make a difference and improve outcome and translate it. And it's not to say we're not interested in the mechanisms and that we're not interested. I think, though, that one of the things that's a little bit different about us, and whether it's at the bench or whether it's clinically, we really are trying to model what's going on in the ICU. Many places would try to have a very simple model, cell culture, for instance, or a very simple preclinical model. But we try to model the ICU. And so the idea that we are really someone that the Department of Defense is very interested in supporting kind of isn't surprising, but it's really been a part of our history. With regard to kind of making changes in the hospital or getting things to really make a difference, I'll try to highlight a couple of the projects and people that we've had over the last 10 or 15 years, and some of the really state-of-the-art stuff. For instance, you may or may not know Rachel Berger, who was one of children's investigators, and Rachel has been trying to develop things that can help you pick up a missed child abuse victim. And Rachel has been a Safar Center investigator for almost probably 20 years now, I lose track, and trying to develop a blood test that'll help pick up a biomarker of brain injury, and or the electronic medical record to try to identify a brain injury. And that in large part was stimulated by her looking at our studies of biomarkers of brain injury in kids in the ICU to try to understand what are the mechanisms happening in the injured brain. We would take the cerebral spinal fluid being drained to relieve the pressure in the swollen brain and trying to understand what is happening. And a lot of those biomarkers She actually walked into my office once and said, "Do you think I could use those in blood, just like you're using those in spinal fluid?" And I said, "Well, blood's kind of far from the action, but take a chance. Maybe it'll work." And sure, try it. And the serum biomarker story now for mild head injury has finally evolved to where there is now an FDA-approved test that they're working now on point-of-care devices to try to get GFAP and UCHL1 are the two biomarkers that have been FDA approved. What's really cool also is that in Operation Brain Trauma Therapy, in all of the preclinical studies, we measured those two biomarkers because the Department of Defense funded that. All of the data that we did were sent to the FDA in the package with the company that submitted that. So all the preclinical research on that was done by our work at Operation Brain Trauma Therapy. So that's one example, but there are others. For instance, right now, Bob Clark, who's the chief of critical care at Children's, he's doing things to try to better monitor the brain in patients. And sure, we have things like MRI and EEG, et cetera, but the intensivist, as I said, treats brain swelling. And a lot of times brain swelling, when the pressure reaches a certain level, it's already pretty far down the road. And we are trying to get ways to tell that the brain is just slightly abnormal. And so he has developed this really novel method of where you couple the end-tidal CO2 from the ventilator to the intracranial pressure, and we are measuring the compliance of the brain as it is slowly getting more tight before the pressure even goes up to a region, to a level that you would be worried about. Okay. And we're finding that happens really early after brain injury. So again, getting back to this, can we prevent badness? Can we catch it early? And in the right patients at the right time, because obviously all of the therapies that we have side effects, and you can't just pour them into everyone without caution. And so these are some examples. I don't know, Chris Horvat, another one of our investigators, is doing a lot of big data work, trying to get the electronic medical record along with some of the serum biomarkers that some of our other team are looking at to try to say, hey, this kid with ARDS who's on neuromuscular blockade on the ventilator, we can't examine him very, very well, but data from the electronic medical record that are continuously feeding out and these biomarkers, this kid might be having a stroke. You can't see it because he's paralyzed. And boom, we would then, intervene, take him down for a scan, which of course you wouldn't do routinely because of the risks, or let them up and try to see if you can get an exam. And so these kind of things are things that we're really trying to do to, again, get the brain, because you don't have a lot of time. The brain gets into trouble fast and it's not very forgiving.
I think that's, I'm really struck by the holistic nature of the approach by so many people from different areas of interest and expertise coming together in the center, as you say, that can cross, multiple divisions and expertise to really come at such a complicated problem from a very holistic nature. It's incredible. It's really incredible.
The one thing I didn't mention that really is part of that also, and that is the link to rehab here. It's very uncommon we have preclinical and clinical investigators in rehab, and we've been working hard to help UPMC Children's build a really strong academic pediatric rehab. They have Amy Houtro, the director, and Erica Fink, one of our pediatric critical care faculty. She's an NIH-funded investigator in the brain and cardiac arrest in children. She has a program she calls CIRCLE, which is Critical Illness Recovery for Children. Yes. And they have the outpatient visiting long-term to try to work with rehab, and really the underpinnings for that are the kids with acute brain injury. That's not to say they're not interested in all of them, but those are the kids that really need the most rehab. And it could be something as subtle as delirium in the ICU, or something as challenging as a severe brain injury from a hypoxic injury, or from a traumatic injury. So it really is from the field all the way to. We have Mia Manoli, one of pediatric emergency medicine people, and she's at the far end, so from the ER to rehab.
Well, Dr. Kochanek, we really appreciate your time today. It's a great story, some great history about the Safar Center, your leadership, and thank you for your ongoing continued leadership and support of all of these, all this, the key sort of bench to bedside work that you've done in your career here. And we appreciate all of these examples about amazing things. Like, one of the things that's cool about this podcast is I learn a ton about what we do here. And although I've known maybe bits and pieces of the story, now I have a much clearer picture, and it's great for our listeners as well. So thank you again for your time.
Thank you.
Appreciate it, and have a great day.
Thank you. And we're really grateful to UPMC Children's. They've been amazing.
Fantastic. Thank you.
You can find other episodes of That's Pediatric on iTunes, Google Play Music, and YouTube. Be sure to subscribe to keep up with our new content. Leave a review, and please tell us what other topics you'd like our experts to cover. Thank you again for listening.